Thank you so much, Jay. I was going to ask you to critique your own presentation in light of the discussions that we've had so far. But I can see you've already started doing that. One of the things that I would like you to start thinking about is the global health agenda. The WHO has sort of three kind of items. The global health security you've included there, universal health coverage is there. But they also have something called healthier populations, which includes climate change and health promotion and so forth. And you didn't quite have that there. I would like you to kind of think about that in terms of whether that is just by design or if it's for some other reason that it's not aligned to what we see from the WHO. And it so happens that I sit on the current Lancet Commission for synergies between the different agendas. And one of the things we've identified is that issues around health promotion are often left behind. It's a neglected area. Let me now introduce Professor SRINATH Reddy, who for many of you does not need any introduction. He's been very influential in the world. He's currently the president of the Public Health Foundation of India, but has contributed a lot to public health in the world. He doesn't have slides. He's going to share wisdom with us by standing here and talking. Professor Reddy, please.
Thank you, Chair. It was not sheer laziness that prevented me from preparing a PowerPoint. It was partly, I thought that it would be presumptuous on my part to prepare a PowerPoint without anticipating the rich discussion that we had earlier. And of course, in the late afternoon, almost towards the fag end of the meeting, I thought it might be also a little impolite to pulverize you with a PowerPoint. So, basically, I am a cardiologist and an epidemiologist by training, but a public health advocate by passion. And in the Public Health Foundation of India, we deal with the diversity of public health challenges that India has across the whole spectrum of health transition. And therefore, whether it is communicable or non-communicable diseases, we deal with all of them. And therefore, convergence is a lived reality for me now. But how do I take the message across to others, whether it's in the policymakers or the academics or the researchers or the wider public? And that is the theme I'm going to address. Because I think the knowledge on convergence which has emerged over the last 1.5 days is sufficient to convince any doubting Thomases that might have entered this room. But it is to the external world that we need to carry conviction about our message. I would believe that we have to necessarily communicate that there is already compelling evidence of convergence across countries and within countries. And indeed, it's not just the convergence in terms of having both communicable and non-communicable diseases occurring in the same population, but also that the social gradient is reversed so that the poor across countries and the poor within countries are the dominant victims. And therefore, in terms of even the equity issue, we have convergence. We have convergence within communities, within families, and within individuals. Indeed, that makes the case for life course epidemiology, which has been long neglected. Again, even epidemiology has been studied in a very segmental, fragmented fashion. We recognize that in an individual, communicable diseases and non-communicable diseases will coexist at either different points in time or at the same point in time, but across the life course, that individual will experience possibly both of them in some manner or other. And now, of course, with the microbiome, we also recognize that this artificial enmity between the microbial world and the human world also has to need a rethink, because what evolution has brought together let no siloed science tear asunder. So we also recognize that health transition is shaping the manner in which this convergence will manifest and the timing at which it will manifest. The direction is clear, but the pace and progress may vary across continents. We know that if Rwanda doesn't now have much of the traditional non-communicable diseases that the high-income countries or even the middle-income countries are experiencing, it is because it is at an earlier phase of health transition. We have to anticipate that there will be health transition propelling those countries also into the next phase and take preemptive action against some of the determinants, including the commercial and social determinants, so that we do not necessarily have those populations also acquiring and manifesting that risk. But we have to necessarily deal with the reality that there is going to be that convergence as health transition evolves. There are different populations across the world who are experiencing that health transition at a different pace. Even within countries, rural India and urban India are experiencing the transition at a different pace. But the direction of transition is fairly clear. And indeed, when we look at the determinants, we also recognize that what Rudolf Virchow said while he was commenting about the epidemic of typhus in Upper Silesia is very relevant for non-communicable diseases. He said, "Do we not always find the diseases of the populace traceable to defects in society? If disease is an expression of individual life under unfavorable circumstances, then epidemics must be indicative of mass disturbances." It was typhus then, related to poverty. It is tobacco now, again related to poverty. Now, in terms of multimorbidity, we recognize that convergence is manifesting in several ways, and that's something that we can actually illustrate very clearly. We are aware of clustered clinical presentations of a diabetic with urinary tract infection, or a diabetic or a person with HIV/AIDS with tuberculosis. Those are very clear indeed. But we also recognize that there are cross-linked pathogenetic pathways. Even when there is no direct assault of a microbe which is causing a non-communicable disease, the fact that it can trigger inflammation, and inflammation itself can become a systemic phenomenon which can cause vascular damage and cause even coronary heart disease. Now, that is something that we now recognize, and therefore the whole idea of having to look at the Koch postulates invariably as the necessary criterion for linking a microbial assault with a vascular injury or a non-communicable disease, I don't think it's any longer tenable. So we are finding these common pathways of inflammation and thrombogenesis which are triggered by microbial infections, for example. So we are beginning to realize that as we explore all of this, that the spectrum of science is reductionist in content, but holistic in context. And therefore, we do recognize that when we studied biology, but biology is also influenced by beliefs and behaviors, and they in turn are influenced by a multitude of social, economic, and environmental determinants. And that is where all the concept of syndemics has come in. As the naturalist John Muir said, when you tug at anything, you'll find it tied to everything else in the universe. Certainly, there is a degree of complexity, but that is the reality of the world and of nature. But at the same time, we also recognize not just the syndemics in terms of multiple coexistent conditions, but we also recognize multiple risk factors operate in concert. The whole concept of the exposome, of not just the genome, but of all the environmental exposures that occur during the course of the lifetime of an individual, and the body's own responses to those exposures constitute the exposome. So it is the genome and the exposome which ultimately interact to produce the disease. And therefore, we recognize that all of these factors need to be investigated and, where possible, acted upon. And for this, we fortunately have tools now. We have excellent tools for data integration, something that we could not have done earlier, whether it is data from social sciences, data from environmental sciences, data from life sciences, data from clinical registries, we have an opportunity to integrate and identify all these connections and also identify which are the key action points where we can achieve some impact early on. So the case is fairly clear. If we move towards person-centered healthcare, community-centered public health, and people-centered public policy, convergence is not a matter of choice. It is an imperative. And that's the message that we need to give everybody, indeed, anyway. And complexity should not be a deterrent. I think we need to try and identify each piece of the puzzle one at a time and build the solutions one brick at a time, but not necessarily be repelled by the complexity that exists. But there are challenges, and we need to find solutions. Certainly, there are barriers to transdisciplinarity, and we have discussed all of those, right from siloed funding streams to lack of credit for multidisciplinary authorship. But we must recognize that policy needs scientific credibility, financial feasibility, operational steerability, and political viability. And for that, you require different streams of research. For scientific credibility, you need biomedical, epidemiological, and clinical research. For financial feasibility, you need health economics to assess both cost effectiveness and affordability. For operational steerability of scalability and sustainability, you need health systems research. And for political viability of how policymakers are going to react, how health professionals are going to react, how the community is going to react, how the industry is going to react, then you require social science research. And we need to bring all of them so that enlightened policy can emerge from the crucible. But this requires a changing of mindsets, and it's not easy to do so. Even in the area of research, to talk about transdisciplinary research is very easy, but how do we make it happen? For that, we do need to act at the level of health professional education, medical schools, nursing schools, public health schools, but certainly at the level of young researchers. What we need to produce are T-shaped individuals, those who have a transdisciplinary understanding, the culture of ability to understand and collaborate, even while they're developing depth in one area of research, where their expertise is going to qualify them as leaders. So it is that kind of T-shaped individuals that we now need to produce. And in terms of grants, certainly I believe there is a very practical suggestion that I'd like to make. Let us ensure that a particular research challenge, a problem that requires multidisciplinary research, there are dedicated funding streams for bringing postdocs from different disciplines together to jointly address that problem and come up with a solution. Unless that kind of a dedicated funding stream is created, either by NIH, by Wellcome Trust and others, we are not going to see the big problems of the day being solved, and you can actually inculcate the culture of transdisciplinary research from that stage onwards of research careers, so that you're building people who can believe in that concept. So that is one. Then I believe, in terms of health systems, certainly the Sustainable Development Goals and universal health coverage provide a great opportunity, and we should utilize that, because done away are the siloed approach of the Millennium Development Goals. We have now a unifying platform which can actually bring in promotion, prevention, and restoring of health into the primary health care in particular, but across the overall health system. But there is health beyond health care. So we need multisectoral action, much of which has been already spoken of. Whether it is tobacco control or food systems and agriculture, we do need multisectoral action. But one of the beauties of empowering frontline health workers and ensuring that we have an engaged and enabled community is that the conversation on health literacy at the primary care level, at the community level, can also educate people on things like tobacco, on appropriate nutrition, so that the demand for multisectoral policy response will actually be generated from those communities, and the politicians will have to listen. So utilize that opportunity. Don't look at primary healthcare merely as a service channel. Look at it as a channel which can actually liberate the communities and make them active in their demand for policy change. And in terms of broader multi-sectoral action, certainly there's a great opportunity for convergence, whether it is air pollution, the indoor air pollution, which is the kitchen's curse, which causes pneumonia in a young child in India, or causes chronic obstructive pulmonary disease or a stroke with ambient and indoor air pollution. Certainly there is a nature of convergence that's so evident already. Climate change, that is again another area of where we can actually bring in multiple players, people engaged in the environmental community. They're natural allies, and the co-benefits are so easily understood. So that is how the message must radiate. And in terms of moving the funders, we have already seen that it's not impossible to move them. The Global Fund created later on a certain percentage dedicated for capacity building. The Bill and Melinda Gates Foundation, which refused to hear about health systems, is now talking about primary health care. As Martin Luther King said, change does not roll in on the wheels of inevitability. It calls for continuous struggle. So that is where we must actually move the field. In terms of priorities, I'd like to reemphasize primary health care and universal health coverage, community engagement, and generate demand for policy response, and utilize universal health coverage, both and particularly policy response both in the health sector and multi-sectorally, and certainly transdisciplinary research. But for these, we need partnerships. We need wide-ranging partnerships across multiple stakeholders. And for this, and because the arena of research extends from molecules to markets, and the arena of advocacy and action extends from risk factors to human rights. So we need to build coalitions. We can't do everything ourselves. But we do have to engage with others who can be the prime movers, and we can support them or engage them to support us when we are the prime movers. Finally, as far as the partnership, I believe I've got a couple of minutes more. I've been given that indulgence. So now in terms of partnerships, private sector features very often. And we have a lot of unease with the private sector, and rightly so. But we ought to redefine PPP, not as public-private partnership, but partnership for public purpose. Define the public purpose, define the deliverables, define the accountability mechanisms, and ultimately let the public interest set the agenda. Otherwise, we will have a lot of difficulty with a laissez-faire system. But on the other hand, we can still mobilize multiple partnerships. Defined that way, you can have partnerships between two NGOs, partnerships between two private sector entities, between the government, one private sector entity, and an NGO. A variety of PPPs for public purpose could emerge. And certainly, we need to go global. We cannot be entirely confined only to local action, even though we have to emphasize local action. In the 20th century, global health received its impetus through a sense of shared vulnerability, bioterrorism, pandemics, and so on. In the 21st century, global health will have to gain momentum from shared values, equity, universal health coverage, of a shared common future of planetary health. And secondly, the advantage of going global is that so far we have been sampling limited sections of the global human family, mostly because high-income countries could afford the research. But we are missing a huge scientific opportunity by not sampling the whole human family and exploring a vast diversity of gene-environmental interactions. By going global, we also share learnings from other health systems, from other cultures, other social organization models, and that can actually advance our efforts to contain both communicable and non-communicable diseases. And many of the determinants are, of course, transnational, whether they're pandemics or tobacco or environmental change or the commercial determinants of health. And finally, equity matters. But we need to focus also on local capacity building. As Miguel Targo, the Portuguese writer, said, universal is local without the walls. So we need to break down the walls. Thank you.
Thank you so much, Professor Reddy.